Good morning, ladies and gentlemen. It's a privilege for me to welcome you at this hearing on the draft opinion, vaccination programs and health systems in Europe. I'm Jan de Maasneer. I'm the chair of the expert panel on effective ways of investing in health. And it's a pleasure for me to present to you the members of our panel that are here. And in the meeting room, we have Ales Burek from the Czech Republic. Ales, can you please stand up? We have Dion Kringhos from the Netherlands. We have Martin McKee from Ireland. We have Ljubna Muraskene from Lithuania. We have Luigi Siciliani from the United Kingdom. And Claudia Wild from Austria. So we are met more than 50% of the members of the panel are represented here. I want to inform you also that there is video streaming. So whenever you intervene in the debate, please speak loudly and start by presenting yourself so that we can record and see who made what intervention. The aim of this session is, first of all, that we inform you about the draft opinion, and then that we hear and listen to your feedback and comments so that we can see what are the things that are missing, what are the viewpoints that are expressed, and that we can improve the draft to the final version that will be debated on the 26th of September at the plenary meeting of the expert panel. So feel free to put any questions you want, make notes during the presentation, because we are not going to interrupt the presenter. But after that, you have possibility at length to intervene, to give your views and your comments so that we can take advantage of that. We are going to start now with the presentation. The rapporteur of this project is Luigi Siciliani, and the chair is Claudia Wind. Luigi, may I please give you the floor and invite you to make the presentation of this draft opinion. Thank you.
Okay, so thanks, Jan, for the introduction. So I'll try to give an overview of what we have done in the opinion. So first I want to thank the members of the working group. It was a pleasure to coordinate the whole group, and I really thank them for the many contributions that they gave to the opinion. So this was really a teamwork. So these are the members of the panel. Many of them, they are here. I'm missing on the picture because I left just 5 minutes before it. So the plan of the talk is the following one. So I'll give a brief background. Then I'll talk about the factors that should affect vaccination uptake. And here I have three main items that I want to cover. One is the overview of what conceptually you would think are the important factors. Then I'll introduce the concept of vaccine hesitancy. And then I'll look at the evidence. So what does the evidence say about which of these potentially important factors are the key ones. And then I'll move to the measures and actions. So once we have an assessment of the issue, of the problem, then we want to try to think about what you can do about it. And so here we have identified three main areas. Many of the policies relate to information and how you can inform people about making good choices about vaccination. Then the prioritization of the vaccination list. And then I'll talk briefly about primary care, the role of primary care in vaccination, which is an important one, and possibly other ones. But then I really want to try to take some time to discuss the recommendations. So based on all of this literature that we looked at, what can we tell in terms of measures and actions? What were our conclusions? So let's start with the background. So vaccination is recognized as one of the most cost-effective public health intervention, but despite this, the EU is experiencing some outbreaks of diseases. So we had fatalities on measles and diphtheria, And this gives you a picture of the cases of measles in 2017. And you can see that they were more prevalent in some countries like Italy and Romania, but also in others like Greece, France, the UK, Germany, and so forth. So the questions that we were asked by the European Commission to try to answer were two. The first one was based on the literature. What are the factors, either on the positive side or the negative side, the enablers and the obstacles that influence vaccination uptake? And then, based on the analysis of these factors, try to assess some measures and actions that could improve vaccination coverage. So that's those were the two questions. So starting with the first one, maybe that's where my health economics background comes in. If you think about the factors that affect the vaccination, you really have to think about the individual decision of why some people do decide to vaccinate and others do not. So everyone, as in many aspects of life, they have to trade off some benefits and costs. So the actions that they take, you can think them as the outcome of an assessment of what are the private benefits that they have from vaccination against the private cost. And again, I'm emphasizing maybe the word assessment. So that's their individual assessment of these benefits and costs. But we know that in this context, there are many social benefits as well. Sometimes they are depending on the context and who is talking about them. Maybe economists talk about this as positive externalities. In other domains, this is referred to herd immunity. So there is a lot of emphasis in the vaccination context about not only private benefits. There are certainly private benefits, but there are also some social benefits. So in the context of vaccination, high level of coverage of the population is essential, because this protects the individuals, but also protects those who are not vaccinated by breaking the chain of transmission. So this is so the herd immunity refers to this proportion of the coverage of the population that you have to reach to make sure that you break this chain of transmission. Okay, so another important concept that also is strictly linked to this individual decision to vaccinate versus not is what is recently referred as vaccine hesitancy, which by one WHO working group refers to the delay or the refusal of vaccination despite availability of vaccines. So the simple idea there is that well, there is a case for vaccination being quite useful, but some people hesitate to do that, to vaccinate. So why is that the case? Well, again, this might be, if you think about these benefits and cost assessment that people have to do, well, that could be either too low perceived benefits or the high perceived cost. And again, here maybe I'm emphasizing the perceived bit. So it's your assessment of the benefits and the cost of vaccination that leads to this vaccine hesitancy. So if we try to unpack this hesitancy, we can try to think, well, what are the drivers of vaccine hesitancy? So following one study, you can classify the drivers of hesitancy according to the 3 C's, which are complacency, confidence, and convenience. So starting with the first, which relates more to the benefits. So some people might think that there is like a perceived low risk of getting the disease. And in some way that's one of the perhaps paradox of the vaccination, that if differently from any other healthcare, is that if everything works well, then nothing happens. Now, if you have avoided like an outbreak, just keep on having like a good health, you don't see that. So that's the perceived low risk it could be like an important component. And the other component which is not on the risk is on the value. So what would be the consequences of not being vaccinated in terms of the disease? I mean, this clearly varies by the disease, but the low perceived value of avoidance of the disease might be an important component. So that's really on the benefit side. So the second C is on the confidence. That's more on the perceived cost. that individuals have, which quite often turn around the safety of the vaccine. So many people seem to be worried about safety of the vaccines and possibly also side effects of the vaccine, which is also related to another factor, which is the trust that people have in vaccine, and you know the trust is also connected to the safety. You know, you don't trust maybe the product, the vaccine, because you're worried that it might not be safe. So that's what contributes this low confidence, which I would say translates into, for the individual, when you're taking the decision whether vaccination or versus non-vaccination, this increases the cost, you know, your psychological cost of vaccinating. And then the last bit perhaps is more like a more economic one, which is relates to convenience, and that's just relates on how easy to access the vaccine. So this could have some price component. Do you have to pay for the vaccine? How much do you have to pay? Though in many countries these are heavily subsidized, but this also includes other components in terms of how easy it is to get the vaccine, how far is the provider, and how easy to get is to get an appointment. So a different way to look at the vaccine hesitancy is to think about domains that influence the decision to vaccinate. So here, following another study, we can identify three main areas. So we have emphasized quite a bit the individual component. There is also a group component. Our peers have a role in our decision to vaccinate. This could be our family or friends, some health professionals. So that's all go under the individual and group influences. There are also contextual influences depending on the country. There might be historic, socio-cultural factors, environmental and political factors, the way the health system is set up, institution, the economy. These might all vary across countries, and you might fit that under context. Okay, so let's now move to some numbers. So there is this nice surveys on the state of vaccine confidence. You can all have access to them if you go on this vaccine confidence website. So we took some numbers from the 2006 project, which are all in the public domain. We just made this nice table. So this table tells you for different countries the proportion of individuals who disagree that vaccines are important for children to have. So you can see that across, in some countries this is a very small number. So in Portugal this is like 2%, and then in many countries this is less than 10%, and then this is at the highest is 15%. So I would say in many countries, you know, most people agree that vaccines are important for children. Now, if you look at the different question, which is the proportion of individuals who disagree that vaccines are safe, here you see a different picture in the sense that you see more variability, and also you tend to see higher numbers. So in a few countries, you still have some values that are less than 10%. So again, Portugal is at the lower end of the figure, but then you have a few countries where this is bigger than 20%. So a significant portion of the population thinks that vaccine disagree that vaccine are safe. So that's I think that links back to this individual decision and the concerns that people have about the vaccine. So it keeps going back to the safety of the vaccine. And then if you ask if whether the individuals disagree that vaccines are effective, then you have numbers that are probably intermediate between the two. So one question that I had when I looked at this data is how much are these data clustered? So if you have a country which disagrees in one dimension, is it the case that they also disagree in a different dimension? And that seems to be the case. So if this graph plots the proportion of disagree on the importance of the vaccine versus the safety of the vaccine, and you can see that there is like a nice, strong, positive correlation there. So in some way, the lack of confidence is clustered within certain countries along several domains. So that's an important point, I think. So I think that suggests that the extent of the issue or the problem, if you want to call it that way, is different in different countries. Not everyone faces the same sort of the same level of hesitancy. Okay, moving to the third part. So we have identified a few factors. Now let's look at the evidence. So here we draw from another review study that focuses particularly on psychological factors, and in some way we again tend to come back to some issues that we have already mentioned. So these I have selected the factors that seems to be more strongly correlated with the decision to vaccine. So again, the safety and side effects, the concerns about the adverse effects from vaccinations, this is an important driver of the choice of vaccination. The perceived risk that the child might get the illness or the disease is also an important driver. The general attitude towards vaccinations. So if you really think that if you are skeptical about vaccination, that makes people very unlikely to take up the vaccine, seems quite intuitive. Recommendations play a role. We mentioned before the peer effects and the group effects. So friend and family, if they do recommend vaccination, this is likely to play a role. And then if health professionals recommended, then clearly this also has a role. Then the parental knowledge is quite important. So if the parents have incorrect knowledge on vaccination, this seems to be an important factor. The information, the quality of the information that they have, is the information adequate or is it not inadequate? If the information is not adequate, then this contributes to make people reluctant to vaccinate. And then the trust in healthcare professionals is also an important driver, which is perhaps not surprising in the sense that health professionals are trusted members of societies. And going to the media aspect, the communication and the media aspect, the messages that people receive, either positive or negative one, these do have also so the evidence says that these are correlated with the decision to vaccinate. So having positive messages influences positively, but if you have lots of negative stories in the news all the time, this also contributes to not taking up the vaccine. I think socioeconomic status is also is an interesting variable in this context. With my health economics background, normally what you see is that education tends to be always related monotonically with a healthcare dimension. So more educated people have better health. They tend to see the specialist more frequently. Here, the story is a little bit more nuanced because there are a few studies that highlight that sometimes it's both the high socioeconomic status and low socioeconomic status that they can both hesitate towards vaccine. Though most of the studies that highlight this, they tend to be across the WHO countries. So when you have like a smaller spectrum, a recent study seems to suggest that maybe within the EU that you'd still find the usual monotonic effect, which says that it's possibly the people with less education that they tend to be more reluctant to vaccinate. Then finally, I want to mention briefly access, which I have already hinted before. So here is just to emphasize that access has many different aspects. You can interpret access as how much you will have to pay to get the vaccine, but this we know that are already free or heavily subsidized in many countries. But this also access is not only how much you're going to pay. You also have the time cost. So you have to take time to bring your kids to vaccinate. How distant is the provider? So all these other costs that we have to face to vaccinate, these are all different aspects of the availability, and these are areas where people can work on to facilitate and encourage people to vaccinate. So this is some graph that we have in the opinion from a study from the Karafil, Lakis, and Larsson. And again, you tend to get the the same hints, the same type of hints. So this is a review of all the studies that try to identify common concerns about risk and benefits of vaccination. And then you find lots of studies that highlight vaccines safety, which we have already mentioned, that is one of the big deterrent. And then another one is the perceived risk of contracting the disease. So we keep getting back to the same point. So perhaps we are repeating a little bit ourselves in the opinion, but we just wanted to have these different approaches to go through the issue. So we have one box in the opinion which tries to bring all this together. I will skip the obstacle ones because that's the negative one. I think I've already emphasized it quite a bit. So we have identified some enablers. So what is that could be positive factors that can encourage people to vaccinate. And these are having reliable information for vaccination, being exposed to positive media message, building trust in institutions and providers, building confidence in vaccines, having an active involvement by doctors and healthcare providers, easy access and availability, which I have just emphasized, and easy of administration, which is also an access component, active involvement of healthcare providers, and then targeting a high-risk group. I mean, there may be other enablers, but these were the ones that we identified as the most prominent ones. Okay, so let's now move to the second part of the presentation, which is, okay, well, now we have some understanding of what are the factors that affect that individual's decision to vaccinate. Now let's think about the measures and action that could be put in place to improve vaccination coverage. So here we do two things. One is to put up a framework for action, and then to identify three common policies. Many policies, they still are around information, trying to bring better information, maybe more positive information, more accurate information to people. And then the others are more around primary care and the prioritization of the vaccine list. So what is the conceptual framework that we suggest? So I think after a lot of thinking, we thought that what should guide action is the herd immunity. So rather than immediately talking about the policy, you should think, okay, what we are trying to achieve here, because there are social benefits and there are positive externalities, is herd immunity. So how can you get there? So in that sense, here policymakers have a menu of options. So they can try to change behavior and increase uptake through recommendations or social marketing, however you want to call it. You can try to remove price barriers or other barriers that people have, so that you can facilitate access. So that's one option. So many vaccines are recommended; they're not mandatory. But if everything else doesn't work, then to achieve the herd immunity, mandation is an option, is a policy option. So that might help you to achieve herd immunity. And this is one policy option that has been chosen by some countries for some vaccines. There are different variants of mandation. So, for example, in some countries you might have that the vaccine is mandatory, but you could allow for an exception reporting, for an exception process. So that, for example, if people are really against vaccination on many grounds, then there is a formal process through which they can apply for an exception. And as part of that exception, perhaps there is they have to attend a meeting with a health professional that ensures that they are aware of the consequences of not being vaccinated. So in that sense, the bit of the mandation is a policy option, but it's not just it doesn't come just in one way. I think there are many different variants. And if something is mandatory, there are normally consequences for not doing that action, but the consequences can vary quite a bit. There might be penalties. The penalties might vary in size, and these are all policy levers which they have to be designed in the specific context of a country. But again, with the view not just on fixating on the mandation versus recommendation aspects, but with the objective of achieving herd immunity, which I think is where all the social benefits are concentrated. So that's our conceptual framework. This is just a slide that I'm not going to go in detail just to flag that there is heterogeneity across countries in relation to whether the vaccines are mandated or recommended. That some countries use more mandation, but also within a country you may have that some vaccines are mandated, others are recommended. So the main point is that there is quite a lot of heterogeneity in the approaches that so far have been used. So there is also one study by ECDC which makes a catalog of interventions, of 40 interventions. So this is a very nice study. It was quite useful, because we were trying to identify all the actions that potentially and measures that you could put up. So then it was useful to have a list of all possible interventions that have been put in place. What was surprising to me was that there isn't actually a lot of heterogeneity in the type of intervention that have been evaluated and put in place, in the sense that most of the policies are around communication. And maybe that's where there is lots of different options, but there doesn't seem to be much else. Well, perhaps maybe we have to be a bit more creative in coming up with the other solution. And then a few policies were about the diagnostics, the diagnostic tools in terms of measuring and monitoring vaccination coverage or hesitancy. But that's just a tool to assess the size of the problem. That's not an action. So in that sense, it seems that most of the action so far has been maybe rightly on communication, but perhaps we can think about policy actions also outside of communication. So just elaborate, because this information aspect is so important, I'm going to elaborate on some aspects from it. I think traditionally the way these communication campaigns have worked is presuming that people are uninformed, so that the way to fix this is to bring the correct information to bring the information to the individuals. I think recently the focus has shifted a little bit. So I think there is now more an understanding that not only people are uninformed, they might also be misinformed or disinformed. So that in some sense, perhaps a way forward is also not only to provide the information, but maybe to correct the misinformation that is out there. So in some way, the traditional principle of communications that have been highlighted in the literature, they are still valid. So if you're designing communication campaigns, but I think there is also a switch in the emphasis there that the communication needs to go not only in one direction, so to provide the information to the individuals, you also have to listen to the concerns that people have, and maybe engage in a dialogue and interaction. That seems to be more useful. And I think in the opinion we discuss in some detail that maybe the traditional campaigns sometimes they may backfire, and maybe they may not be as effective as they can be if instead you engage a little bit more in a dialogue. Now, this dialogue aspect might be a bit costly, because when you are, if you're setting up a dialogue, you need people to do that. But that's, I think that seems to be an important component. So across different communication strategies that we have tried to highlight, we have. We again, relying on some other studies, we highlight that bringing champions, trusted champions to community, maybe communities that are very hesitant, might be a good policy options. Face-to-face exchanges with individuals, perhaps through healthcare professionals or other professionals. It doesn't have to be always the GPs or the healthcare professionals. So these are all important communication strategies. So okay, so I'm now coming on towards the end of the second bit, before I go to the recommendations. So we also discussed a little bit the prioritization of vaccination schemes. Different countries again have different vaccines, but they're all trying to do the same thing. That they are trying to identify which one are the most cost-effective vaccine in their own context. Here, health technology assessment is a useful instrument, and there are many frameworks that policymakers can draw on to make these decisions. So here we haven't gone in great details, but that is to come up with the right list in each country and to justify it seems to be an important issue. And then very briefly on primary care, just a couple of points. So primary care clearly is very well positioned to improve child vaccination rates. This is due to the possibly frequent interactions that you might have between GP and families and kids. And our impression that that there is still scope for several policy refinements around GPs. So one that really seemed to come out quite systematically is that reminder systems for healthcare providers and parents seems to be working. So that's that maybe seems like a small detail, but maybe this is some of the improvements could be in the better design of the interaction between primary care and the parents. Perhaps some financial incentives might also have a role, and maybe better integration between public health and primary care could also help. Okay, so I'll now move to the last bit, which is the recommendations. So based on what we have analyzed so far, what is that we can give in terms of policy advice. So the first one is in terms of communication strategies. So this seems that they still remain important, that they are an important component of for ensuring that vaccination uptake keeps improving. But perhaps there needs to be a switch from to a more participatory approach, where there is a dialogue. So that people have an opportunity to raise their concerns and get their replies. I think that this is we thought that this was an important component, which is related to which also related to people being uninformed. That's one way to improve the disinformation, the fact that people are uninformed. And we also emphasize that the focus has to switch not only from people being uninformed, but also trying to address the misinformation and the disinformation a bit. So that it's not only about bringing the right information to the individuals, that they were lacking the information, but also to try to correct the information that is put in the public domain that might not be correct. So here there is where we think that at the EU level there might be scope for further improving in terms of advocacy and the communication strategy to promote value and safety of vaccines, to promote effective intervention strategies, incorporating these participatory approaches. So the second recommendation, which really relates to the way to think about the action, is to put the herd immunity as the goal to try to achieve, and then to think about, given the context in a given country, how do you get there? Do you do this through a more recommendation type approach, or do you do it with mandation, which we know that in several countries can be quite unpopular. So in that sense, I think we have to be careful and mindful to make sure that we do the things in the right way. And also I want to emphasize that there are different variants of policy options, so that you could have, again, for example, mandation, but still allow people to have an exception to being exempted, but on the basis of a costly process and the formal process that ensures that they do have the information, that they are doing that choice, but they are aware of they are well aware of the consequences that might arise in terms of the risk of getting a disease. So again, I'm emphasizing that the herd immunity should remain the priority in designing the policies. And then primary care, as I just emphasized a few minutes ago, I think is well positioned. So we can still think how we can further improve the role of primary care. These are trusted, people trust doctors. They are generally very well trusted in society. They also have frequent interactions with parents and children. We go and see the doctor for all sorts of other things that are unrelated to vaccines. So that gives an opportunity to bring the vaccination bit in and making sure that there are opportunities to discuss this. And as I said before, the reminder systems seems to be a quite effective policy intervention. Now, one point that we discussed in some detail with the working group is that there is a lot of emphasis on the primary care, but primary care does not have to be the exclusive providers of vaccination. So if you're thinking about improving access and the availability of vaccines, there can be other providers that they can provide vaccine. It doesn't have to be only primary care. So pharmacies, community pharmacies, nurses, community care providers, other qualified providers, including within schools, with working hours, outside of normal working hours. I think this is an area where we can be creative and trying to think how can we improve access so that we can facilitate and reduce that private cost of getting the vaccination. So that's an important conclusion in my view. And if you do introduce this diversity in provision, that reinforces the case for having integrated approaches towards vaccination records. So if you're going to have many different providers in the system that they provide the vaccination, then there has to be like a unified electronic vaccination system to input the information so that we have accurate records about this. In terms of access and in terms of the cost and the price that sometimes in some countries you have to pay for vaccination. So our conclusion was that, well, already in many countries that the vaccination is free or there is like maybe a small copayment, but clearly many countries are struggling with reaching the adequate vaccination coverage. So letting people pay for vaccination seems contradictory with what the objective that we are trying to achieve. So our suggestion was that as much as possible, vaccination should be free of charge. So the last recommendations that we have is in terms of the differing lists of vaccines that you might observe across different EU countries. So I think this potentially, so if people see that different countries have a different list of vaccines and different rules, I think this is a potential source of confusion. So I think that there is a case, I think, for either to explain to people what is the rationale for these differences, or perhaps there is a rationale for harmonization and improved coordination and consistency. So as final conclusions, we also support having a good monitoring system and good surveillance system. I think that seems an important necessary condition to make sure that you have the right assessment of the problem. So you need to make sure that you have the right information to make sure that you know the extent of the people that are not covered by vaccination. We also support, and we thought that there was scope for more cooperation between public health and primary health care services. Although we haven't talked so much about equity in this opinion, we still thought that vaccination could be also a tool through which we can get more equitable access, better access in health systems. And that's it. That's it. Thank you very much.
Thank you very much, Luigi. I will take the chair over there and take a seat. So, ladies and gentlemen, it's now time for you. to intervene, to question for clarifications, questions where you want to bring in new perspectives, other opinions. May I kindly ask you, in view of the report, to clearly start with presenting yourself, your name and your context, and then formulate a point and try to be as concise as possible. So we prefer one intervention ending with one clear point, and then you can do a second one and a third one, because if we confuse everything in one intervention, that's not so easy for us to take notice. The important thing is that we capture your feedback and that we can take advantage of that in making this opinion better. So the floor is yours. Please present yourself.
It's real close to the...
Okay. Good morning. I'm Lien Meulenbergs. I'm the WHO representative to the EU in Brussels. This is going to be very difficult because I want to read from my mobile. Try to. And I'm very pleased to be here. I want to commend the European Commission's leadership and the experts for the report that is here presented. Yeah, okay, then it makes a noise.
I think it's because it's close. Feedback will go away.
Because of the speaker. Better? Okay.
Yeah. You have to eat the microphone.
Apparently. I had a good breakfast, so I'm not really hungry. We think that this is a very timely discussion, especially considering the large measles outbreak and diphtheria cases across the region, as we reported in August. So our midterm review on the European WHO Vaccine Action Plan was carried out this year, and we identified a number of existing challenges. And what I want to share with you is a few elements that are, in our view, very consistent with the expert panel report, and a few topics that are maybe interesting to highlight a bit more. I'm not going to go into the midterm review. That will be discussed next week in the regional committee in Rome, so I will really limit myself to this. We feel that the report is well aligned with our WHO Vaccine Action Plan. They espouse about equitable access, high quality, safe, affordable vaccines, immunization services throughout the life, and so on. So that's all pretty impressive and very good. The first element I want to highlight is high immunization coverage rates are critical to achieve herd immunity, as was discussed. But we would like to reiterate the importance of achieving high immunization coverage also at subnational level. While coverage at national level might be high, immunization gaps at subnational level can sustain and perpetuate vaccine-preventable diseases. So equitable access at immunization services through primary care and other providers is critical to achieve that also at subnational level. The second point is, and it was highlighted, participation and dialogue with communities is, in our view, very important to identify the often complex reasons, as was also in the presentation, of low vaccination intake. Tools, guidance, and training materials related to behavioral insight, formative research, and communications are critical to understand that, to understand why, what is the end user's experience, and what is the demand on these immunizations. And my final point is the need for a high quality service and immunization data cannot be overemphasized. An effective information system connecting all immunization data elements, electronic immunization registry, disease surveillance system, vaccine supply, cold chain management systems, they are all critical to guide policies and to plan immunization. So that is an element that might also be a bit more stressed in the report. So these are the three comments I would like to make, but I want to congratulate the expert panel for its report. Thank you.
Thank you very much, Mr. Meulenbergs from WHO. So, alignation with WHO action plan was your first point. Then, of course, look also at the subnational level. And if you look today where there are outbreaks, that's a subnational issue. Very often it's not the whole country, it's specific. So be aware of that. Go for participation and dialogue, looking at the upstream reasons and behavioral change and insights. And finally, information systems and data are crucial. And did I hear you say we should have a European international system where we can have the data of people, or is this a bit difficult in GDPR times?
I didn't say that.
Okay, you didn't say that, clearly. Other comments from Claudia, Luigi? I think these points are very clear. Yeah? And we thank you for it. Thank you very much. Next intervention, please. First. Yes, please.
Good morning, everyone.
Stand up and present yourself.
Good morning, everyone. My name is Jan de Wely. I work for the PGU, which is the association representing European community pharmacists. I want to say that we very much welcome and support the report, and especially the recommendations regarding improving access and convenience by also making other community healthcare providers administer vaccinations. I think we want to stress here that in the existing countries where this happens, we see very good results what covers the complementary role that other healthcare providers have to increase the vaccination coverage. For instance, in Ireland this year, there's a very good flu vaccination coverage increase, which was not only because of extra pharmacists having extra vaccination coverage, but also the GPs, the vaccination coverage got up, which shows that in terms, when you open this vaccination administration to other healthcare providers, there's no such thing as real competition, but complementary efforts. And I think here we really want to stress as well that the general multidisciplinary approach within primary care regarding vaccination is that we really strongly support it, because that will not only improve access and convenience, but will also make sure that healthcare providers and community care providers as a whole become one strong group of advocates for vaccination. So there it's really important that we have centralized high quality information for all these groups, make sure that we have indeed very good registration of the vaccination records in electronic healthcare systems, so that all providers also are aware of which vaccinations have already been delivered, which ones recommendations can still be made. And I think, yes, the strong multidisciplinary approach in primary care has very good opportunities to increase further the vaccination coverage in Europe, especially if you talk about herd immunity and knowing that different patients have different access points within the healthcare system.
Thank you very much for this. This was Mr. Jan de Wely, PGEU, and if I grasped it well, you say positive report. It's important that we make it a joint effort, interprofessional effort. You mentioned the role of community pharmacists, and you even said that joint responsibility for vaccination will stimulate joint advocacy and improve the outcomes in double wins. If that was more or less your intervention?
Yes, and especially focus on the complementary efforts to increase the vaccination coverage rate.
Thank you very much. Please, next intervention. And then we go to you.
Well, good morning. My name is George Griffin. I'm Emeritus Professor of Infection at St George's Medical School in London. Been involved in vaccine research for many years, been on the UK committee, JCVI, and Gates committees for developing country vaccination. I'm here representing FEAM, Federation of European Academies of Medicine. I've got several things to say actually, but first of all to say I really like the report. There are one or two omissions, however, which I would like to mention, and I've already had a brief conversation with Luigi about this. The first thing is very pedantic. Vaccine hesitancy and the WHO definition, which Luigi said, actually it should be vaccine hesitancy leading to refusal, because it's the refusal which is the important thing. The hesitancy is of course important, but it's the refusal of vaccination which is important. I think we've seen today that a simplification of vaccine schedules is desperately needed, and some way to try and bring within Europe some confluence. Now, for example, in Germany, I understand that the different Länder have different vaccination schedules. So there is difference within an individual country, let alone between countries. Education, crucial, as we've all seen. I would add to that, or I would consider adding to that, education within schools. In the UK, we have health education in primary schools now. This may be too early, but education later on to explain what vaccination is, because these young people will become adults, and you're setting the seed for the future. The other thing which I think does need mentioning, and the topic is hard to reach groups. And there are special groups which are very hard to reach, and of course in Europe we have the refugee problem, which is very difficult. Millions of children, millions of adults, let alone children, who have not had proper vaccination, and they will undermine the herd immunity which we talk about. So I would put them as one of the hard to reach groups now. But of course there are other hard to reach groups, vagrants, people living on the streets and so on. The other thing which I found ambiguous in Luigi's talk was the cost of vaccines, because this is a cost, if we're talking about financial cost, it's a cost to the individual, unless, as in the UK, vaccines which are approved are completely free. Now, for example, there's been great discussion recently about human papillomavirus vaccination for boys. It's been accepted for girls who become women, and we know this works for against cervical cancer. The argument for boys has been less strong, and people have actually been paying a lot of money for their own private vaccination of teenage boys. This has now been accepted by the JCVI. So it's to try and define costs, financial costs, in terms of individual costs and in terms of governmental costs. The government will only introduce vaccines if it's cost effective, of course. That's the first thing we all know about. The other thing which is missed out is healthcare workers. Now, healthcare workers are vulnerable to infection because they work in healthcare. And if you look at influenza, there's a terrible lack of uptake of influenza vaccine in healthcare workers, and this does need to be addressed for the reasons that I needn't go into. The other thing is compensation for vaccine challenges. Now, New Zealand has a very interesting no-fault compensation scheme. It's quick, it's easy, and if there is a side effect of a vaccine, there is a very simple way of doing this. In the UK, we can have 5-10 years of arguing between whatever, and this needs simplifying, because even though vaccines are safe, and I would say that, wouldn't I, there will be complications, and so this is needed. Prioritization, I agree entirely with Luigi's comment, and I thought Luigi's slides at the end, the conclusions were excellent actually, but prioritization is really one of the crucial things. And then the last thing, well, two last things. First of all, the vaccine industry has to be mentioned. Obviously, there are conflicts of interest because they want to sell vaccines, but there has to be some work with them. Now, I can give you an example in the UK. When the meningitis B vaccine came out quite recently, the cost was absolutely huge, far, far greater than the government could afford. But it was talking to the industry and getting the cost right down, and I believe it was about halved. So there must be dialogue with industry, and that could go in the cost bit. And then the last thing that I would say, and it may not be the remit of your report, is that research into vaccine science must carry on. And I'll give you an example of that. At the moment, the Sabin oral polio vaccine is getting a lot of criticism and has been stopped in many places. And the reason is it's a live vaccine, it mutates and causes flaccid paralysis. So Sabin is out, we're into parenteral injectable vaccines. The question is, what do you use for your source of virus to make the preventable injectable vaccine? Because if you use Sabin, and this can get out into the community by mistakes in industry, unfortunately, you will have a mutatable virus which is out. And there's a search now for a new polio source to make the vaccine. So that just highlights the need for continuing research. Now, I'm sorry, you did say you only wanted 1 point, and I've gone on a little bit, but I hope that's been useful.
Thank you very much, Mr. Griffin. I think...
Sorry, I don't destroy things usually.
I think you mentioned a lot of important points, and I just, in terms what came to my mind as very important message are simplification of schedule and European confluence, the hard-to-reach group, especially the refugee problem. Yes. As a family doctor, we are working in Ghent here, where we see people and you don't know about the vaccine status. They have been on an island in Greece. They have received some injections, but you don't know where you are. And I think that's really a challenge in order to have an adequate response. So that is absolutely, I think, a point you made very clearly. The healthcare workers, I think this concern absolutely clear. We know that healthcare workers are not the best people when it is about compliance to the things they should do in terms certainly of vaccination. So certain area for action. Interestingly, you mentioned the compensation with the no-fault scheme from New Zealand in order not to go into debates and insurance issues and so on. Take the vaccine industry on board to negotiate together was one of your other messages, and carry on with research. There's still a lot of questions that should be answered. I think that are some of the important issues that you mentioned to us.
Thank you.
Yes, thank you very much. Please, we give the floor now to the next intervention.
Thank you. Hi, I'm Daniel Schubel, and I'm speaking on behalf of the German Medical Association, the representation of physicians in Germany. So first of all, I would also like to thank the panel for the recommendations and for the report, which contains a lot of good ideas. And I would like to start off by raising a point of caution regarding the fourth bullet point of the recommendations. In our opinion, one has to make sure that the vaccination process itself is safe and that it is carried out according to the highest medical standards. Physicians are a group that have been trained to be aware of risks and possible side effects and of vaccinations, such as anaphylactic shock, for instance, and to take into account possible underlying illnesses and conditions of patients. So we have to be careful that the whole process is, of who gets to administer vaccines is closely monitored and thought about at a policy level as well. But in order to achieve a high vaccination cover, we think that all physicians should be allowed to vaccinate, which is not the case in all member states yet.
regardless of their specialization. So pediatricians should be allowed to vaccinate the patient's parents, for instance. Gynecologist should be allowed to vaccinate the patient's partner, and so on. Other health professions are also vital. We see that point, definitely. And they should be allowed to vaccinate as long as this happens under supervision of a trained physician. Also, pharmacists could be allowed to administer certain vaccines if they have received the necessary training and and if they're aware of the possible risks and side effects. But this is an option we see more likely occurring in a major crisis such as a pandemic outbreak. And on one point that has been raised before, like during the interventions, the obligation of healthcare personnel to be vaccinated, we fully support that, but we don't believe in a mandatory option, but we prefer an indirect obligation, which could happen, for instance, if new healthcare personnel before being hired would have to declare or prove that they've been vaccinated before they enter into service. Thank you.
Thank you very much. So this was an intervention by the German Medical Association, Mr. Schumann. It was mainly about who is going to vaccine and how do you organize that. And you mentioned concerns in relation to safety, and formulated some concerns when others than medical doctors are involved. And you mentioned especially training, supervision, and finally you addressed the issue of vaccinating the health professionals. Thank you. Yes. Martin, you wanted to? Yes. Please.
So maybe I'll begin by setting out a conflict of interest. I am a physician, and I think we have to be evidence-based here, and I'm unaware of any evidence anywhere that vaccination by suitably trained nurses or pharmacists, providing they've got the training, and that equally applies to doctors, because not all doctors necessarily have the training. I'm not aware of any evidence that is in any way harmful. And in fact, in many countries, nurses take the lead in doing this, and in some cases, the doctors report to the nurses, which is a perfectly acceptable way of doing things in a multidisciplinary team. You raised the issue of compulsion and mandation. NHS England is proposing that health workers in critical areas like intensive care, oncology and so on, who refuse to have influenza vaccine could be redeployed. That is an option. I don't think anybody's suggesting anybody should be dismissed for doing it, but I think ethically, as a physician, I feel strongly that, and I get my flu vaccination every year, I believe strongly that I have an ethical responsibility to the community to be vaccinated. And on behalf of, given that we know that even with vaccination, of influenza vaccination, it's not 100% effective. We desperately need to get those rates up, and I think it's really seriously unethical for any health professional not to be immunised. But I really see no evidence whatsoever that we should require nurses to be under medical supervision. In fact, it's perfectly suitable, perfectly appropriate in many countries for the doctors to be under the managerial supervision of nurses. That works well.
And this is a real paradox. And
Mr. Griffin,
an informed group of people, intensive care nurses, where the vaccination rate for influenza is often 20% in units. I mean, it beggars belief, and we need to do some research as to what happens. I've seen that in my own hospital, actually, despite the fact we have a walk-in clinic open for a month every autumn for vaccination. It's a real paradox, and it's not the uninformed layperson, it's the informed professional person, which is quite bizarre.
Yes, there's a difference between knowledge and attitude and behavior, and I think that we should learn more about that. I see some reactions. Lady, please, and then yes, please.
Not a reaction, it was to jump on another topic. So if there are reactions to what is currently...
Are there people that want to react on this issue? Yeah, Mr. De Bailey? Short, if you can, and then we will pass the microphone back to you.
Yes, hi. Jan De Bailey again from the PGU. I fully agree that for minimum requirement for delivery of vaccination should be a very good training, not only on how to deliver, but also in other things, as you said, how to deal with anaphylactic shocks, etc. So there I fully support, and just to inform you that in the countries in Europe where also pharmacists can deliver these vaccines, these trainings are exactly as you say the minimum requirement. So they are often 2 days courses which have recertification every, depending on the country, 2 to 5 years, certified often by the Ministry of Health, and even the training is then provided by, for instance, physicians. So I fully agree that we cannot get people to vaccinate without proper training, and make sure that these people are very aware of all the potential safety risks. But to say that when community pharmacists at this stage in Europe, where it happens that all of these trainings, they exactly take place also on the anaphylactic shocks, etc.
Okay. I think then with that we have clarified this point, and thanks for the interventions. May I please ask you to take the floor?
Hi, I'm Sibylia Quilici. I work for the pharmaceutical industry, MSD. Sorry.
Eat your microphone,
yeah,
please.
we really have to eat it as we. So I'm Sibylia Quilici. I work for the pharmaceutical industry, MSD, and I wanted to emphasize the need for, which seems to be missing in the report, for a holistic approach to vaccination, with regards to the rationale why people need to be vaccinated. And for them also to understand, we often have an age-based rationale, but when we see, for example, the aging population that needs actually to get vaccinated against influenza, they don't feel old and at risk for getting these vaccines. So maybe the age rationale is not enough. And based on also the experience from Australia, Australia has a quite good approach with regards to the life course, where they don't actually define the rationale for vaccination only on age, but they have an acronym they called HALO, which is health, for the health status, age, lifestyle and occupation. And indeed, depending on your health status, if you have diabetes, a chronic disease, for instance, you may be eligible for vaccination, because an infectious disease can actually impact your underlying condition. With regards to the lifestyle, it depends on who you are, where you live, and with who you live. I mean, for parents, for example, there is a good rationale for getting pertussis vaccination if there is a newborn. Or if there is actually a child or someone from the family that is depressed. This kind of rationale. With regards to occupation, it goes back to the point of Mr. Griffin, is depending on where you work, you have a good rationale also for being vaccinated. If you're healthcare professionals, but not only, wherever you are exposed to potential infectious diseases, if you travel a lot. So could we actually get this actually in the work that is done? We need a life course approach to vaccination, and also for people, I believe, to understand that it is not only about age. It is really about who you are as an individual, what are your risks, and it may also help adhering better to the programs.
Thank you. So this was an intervention by a representative of MSD, pleading for a holistic approach, referring to the acronym HALO, looking at health, age, lifestyle and occupation, in order to have a more comprehensive approach and not only using age. I think Luigi Claudia is... you can pick that up.
Yeah, I think we can think about this. I think the opinion maybe is reasonably holistic at the moment. I think we try to approach this in a very broad way. But it is true that we haven't gone into the aging issues specifically in much detail. So time permitting, we might maybe try to think a little bit more about the age-specific issues. I can see that there are some issues in terms of people not feeling old, and then they think like, I don't need the vaccination.
Okay, thank you.
But I think that the topic is somewhat touched by the electronic reminder system, that with aging you will be reminded that possibly you need another vaccination you haven't had yet.
Okay. Other interventions, comments, adds on, please in the backstage.
I'm Paul Kokken. I'm working at TNO, but I'm part of a consortium, MOCA, Models of Child Health Approach, which I represent actually at this moment. And this is a Horizon 2020 consortium. We did some research also among experts and among the target group, and the target of MOCA is to appraise models of primary child health care in Europe. What we found with regard to vaccination, which is a use case in our research, is that, and that very much is in accordance with what you recommend. So my compliments very much for your analysis in your report. Is that the communication was found more important by the experts than a really change of the system, the primary care system for children. Communication was the real about safety of vaccines is the most urgent thing to do. However, with regard to the systems change, it was recommended, and then I want to support one of the things that is said, but by the lady of the WHO, is the electronic record systems, which is a very important thing in to improve in especially case-based record systems and also unique identifiers, and this is now researched by MOCA at this moment. We don't have the results yet, but we're working on the end report, and we will have a workshop next week together with another H2020 group of research group, Trillium 2, who are looking at patient summary. So we are making an inventory of the European countries. Where do they have these electronic systems, and do they work or not? Is it case-based or not? So that's an important thing to advise, also to do further research on, and to develop. And the other thing is, and that's also said about workers in healthcare, to train them, and especially if you propose an option, opt-out option, then it's very much important to train them.
Thank you very much. So, Mr. Kokken from Horizon 2020, Mother and Child Health, you focus on the importance of communication, certainly when it comes to children, also in the framework of primary care, and then you very strongly make a plea for we have to have integrated IT systems that should be case-based registries of what the state of affairs is for a certain person when it comes to vaccination status. Yes, and then you give some recommendations for research, looking also at this structural components that can underpin the performance of vaccination strategies, and special attention also to, if any, the opt-out procedures and how to deal with that. Thank you. Please, take the floor.
Thank you very much. Stephanie Cole from the European Association of Hospital Pharmacists, EAHP. We also want to thank you very much for the presentation of the report, which is very, very useful, and some very good points were made. The only component that we find lacks a bit is the emphasis on the education and training, because you mentioned several times the importance of the participatory approach between the patients, citizens, and the healthcare professionals. And I think in order to foster and enable that, it's very, very crucial that the healthcare professionals that in the end administer the vaccines or talk to the patients are properly trained on how to actually approach and discuss with the patients the misinformation or disinformation component that you mentioned. And then in addition to that, it would also be very, very important that patients receive the appropriate information from sources that also they on their own can explore the components of mis or disinformation.
Thank you very much. So on behalf of the European Association of Hospital Pharmacists, you very much emphasizes the importance of training healthcare professionals in order that they have the skills and attitudes to really perform well when it comes to interaction in participatory way. And also access and information is important, and direct access is important. Of course, in that respect, there is a problem that there is a lot of information that's not scientifically based actually on vaccination. If you use vaccination and you enter it to your search machine, the first 3-4 websites that show up probably will be with pleas against vaccination nowadays and not based on scientific evidence. Yes, please.
Hello, Paul van Hoof. I work also for a pharmaceutical company, GSK, one of the largest vaccines producers in the world. Two things. To the life course immunization, I think what is important to realize that we are used to a population that children should be vaccinated. Yeah? And with the waning immune systems, when you get older, it's really a different perception. And I think we should all work on that. People really understand that being revaccinated or vaccinated against disease for elderly is very important. So that is a nuance to what was said. To the last recommendation, I've been working for the last 6 years with Roma communities in Eastern Europe. And I think in your recommendation, it's so important to re-emphasize that there are vaccines available for whole population and often also for Roma people, for example, but they live in such a secluded circumstances that the access to healthcare in general, and not only for vaccines, that is where the issue is. And I think that is also something really to look into how we can improve that. And for example, the role of Roma health mediators, I've been working with them and they make a big difference. So this is, Martin, we can discuss this later as well, but really, this is really something to look into as well. Yeah. Okay.
So thank you, Mr. Van Hoof, working for GSK. The lifetime approach, putting in perspective and also making sure that it is a complete lifespan that should address the status and the vaccine status and the immunity status of a person. And then you make a strong plea for the attention towards the Roma community. I think in our previous opinions we have devoted special chapters to the Roma community. So maybe Martin, can you say a few words on that?
Yeah, I mean, absolutely agree that there is a real issue in, and it is an issue of access to healthcare more generally. And I'm sure you're familiar with the European Roma Rights Report, Ambulance Not on the Way, which captures the reality of that. And we've, wearing my academic hat, published a paper you may have seen on the vaccine gap in the Roma population. I take your point that many Roma health mediators do a very good job, but it's not that straightforward. One of my colleagues recently spent 18 months living in Roma communities in Romania, doing a detailed ethnographic study. The problem is that there are so many structural barriers to Roma getting access and the way in which they're marginalized and systematically discriminated in a number of countries. It's a really, I take your point, it's just a really, really difficult situation, and there are no very easy answers, but we actually desperately need to get the structural barriers, providing services in the communities that people live, and then questioning whether they should be living in segregated areas at all. And in some cases, and in this example in Romania, living in disused shipping containers.
No, I fully agree with you.
Yeah, I think we're agreeing, but just saying it's complicated.
Yeah. I think it's an absolutely important issue. I've been 25 years responsible for medical education, and one of the failures, things that I never reached, was to bring Roma young people to become doctors and nurses. And we tried all kinds of strategies and it didn't work. So I think there are real structural issues because that's also one of the ways to make the access much more feasible if you have people from the community themselves that can be involved in healthcare provision. There was a reaction from Mr. Griffith, please.
Sorry, I hope you don't mind me speaking again, but several things have come up. Well, you mentioned medical education. I would put medical students in that as well.
Yeah.
Because, I mean, in my medical course, I had no education on I mean, this was a million years ago, of course, but I had no education on vaccination, how it worked, why it was important. And we should really have that, not just in the pediatric practice. And that leads me on to my support for the adult vaccination. In the UK this year, we are having special flu vaccine for over 65s, which is adjuvanted to give a better immune response. And that is different from the quadrivalent vaccine, which is given to the under 65s. So we're beginning to appreciate that as important. Comment about mandation, which is quite interesting, actually. I did some work in Brazil on TB vaccination one time. Unless a child was vaccinated with BCG by the age of 4 weeks, they were not allowed to go to school. And that was the way that mandation worked in Brazil, and they all got vaccinated. The problem then was when the children reached teenage, there was an epidemic of TB meningitis because the immunity had failed. And that's why I said we've got to keep an eye on the science and evidence base. Sorry, I will not say anything else.
Thank you. I think the point you made was clear. Are there other concerns of points that need to be added or that should be more clarified? Please, Mr. De Bailey.
I will just very briefly indeed complement what was just been said regarding education, medical education, on these very important public health topics such as vaccination and AMR, where a very multidisciplinary approach is needed within primary but also in connection with secondary care. I think the good practices already exist on interprofessional education on these topics. For instance, vaccinations involving medical students, pharmacy students, nursing students are very important, because when we talk about the same level of high quality information, the same approach towards patients and communities, I think there already in education this multidisciplinary approach is a very good opportunity.
Thank you very much for this reflection, and I think the fact that the report also makes a plea for integrating more the primary care and the public health goes in that direction. And I see this kind of movement actually happening in many countries in the European Union. Okay. Good. I don't see no more interventions. Isabel de la Mata, you are expert in the DG. Do you want to add or to give some comments on what you have seen today or the interventions?
I think that the opinion on the document is a very good one, reflects all the issues that need to be taken into account, and that also pave the way and say where we will need to work and concentrate in our efforts to strengthen the cooperation against vaccine-preventable diseases. So this opinion is going to complement other activities that we are doing at this moment, as a fish per country to see how the vaccination services are organized, and to see if there are ways that work well, better than others, and also the confidence report that we are doing with the London School of Hygiene and Tropical Medicine and Heidi Larson that you are also mentioned, and that we have made an update for the situation in 2018. So this is a corpus of different studies that will feed the discussion that we are having with the member states in the Council, and that we hope that will lead to the approval of Council recommendation in December in the PESCO Council. April. Also, the European Parliament made an opinion on April this year. So I think that now there is a moment. Lynn Mellemer mentioned that next week we will be discussing the action plan and how is performing and advancing in the regional committee in Rome. So I think that now is the momentum that everybody is working on vaccination. Everybody sees the point. I think that the measles outbreak and the several deaths that we unfortunately had last year made people aware that we have an issue. I will say that even that we have a problem and that we need to solve that and that we need to go. So thank you very much for that. And the intervention of the participants were also very adequate and pointed some points that deserve reflection for the next version. And I think that now we have 2 weeks. You have 2 weeks to close the excellent work and to approve and to publish and not just to have another publication, but really to discuss about that and to use that. Thank you.
Thank you very much. So we are coming now to an end, and I would like to invite Claudia Wild, the chair of the working group that prepared this endeavor, to bring some final remarks, and then I invite you to the buffet lunch, which is offered here. Please, Claudia.
It's my task to summarize what we have been talking about here, and for summarizing I would like to go back to the very beginning, why we are here and what this opinion was all about. And the opinion was all about to support the European Commission in their policies, what kind of measures could be taken in order to increase the uptake. So none of our ideas, I would say, are new, but potentially the focus of our ideas, and we focused especially on 3 issues, is the specific ones. And I found this adding discussion here very, very valuable in order to finish our report. So our opinion was focusing mainly on 3 issues. The issue on informing on communication, and not only to inform about misinterpreted facts or about facts that are incorrect facts, but to go into dialogue with those who are skeptics, or to go into dialogues, or to actively react to misinformations. And I think this was very much supported by your input, that this dialogue or participatory approach is also supported by you. The second part is to be more differentiated, not only in concerning prioritizing vaccines, because not all vaccines are equally important or equally effective in all populations or in all settings and in all countries, but to be a more differentiated in concerning policies to take or to implement with the final aim to increase the uptake. And the third interventions, or the third focus of the opinion, is to strengthen the primary healthcare sector. And this was also very much supported in this discussion right now. Although not all of you, or especially the physicians, there was a certain controversial issue about the fact that we proposed that not only physicians but nurses, community nurses, pediatric nurses are allowed, as long as they are trained, to do the vaccinations, but to open up also to physicians, pediatricians, to vaccine the families of the children. So make it a joint effort of everybody in this field to increase the vaccination rates. I try to bring together or to synthesize your remarks without intending to repeat every single detail, because it was very well done by our chair. But I think the role of integrated IT was strengthened in several of your remarks, that we need to bring together the data. We need data in order to make evidence-informed policies on increasing vaccination rates. we need to approach, we need targeted approaches to subpopulations, and not only for an equitable access to the vaccines for real subpopulations, like we were talking about the Roma people, but I would even call the healthcare professionals who are not willing to vaccinate themselves as a subpopulation that needs to be targeted especially. Yes, and then there was the issue of the holistic. Actually, I didn't really understand what you meant by holistic approach. But later on, when your colleague was talking about the life course approach, it was clearer to me what you meant. That possibly the integrated IT, would help us with reminders and re-vaccinations in older life or in advanced years. And then, of course, we need research. I think we need to incorporate research, but not only research in vaccine science, namely in the setup or in the chemical or in the biological part of the vaccine, but also on behavioral science, why some groups, even the educated ones, are really hesitant to get the vaccines. Yes, and then there was the issue of education and training, especially in communication towards those who are in need of vaccines. So the training for healthcare professionals is of utmost importance or urgency. I would even say urgency. The training in communication to not only to be communicate polarizing issues, but to react to hesitancy in appropriate manner. And I hope I summarized everything. But of course, there is more details on my page, and there's more details in your page. And the next steps now will be that we will reconsider your comments and incorporate them into the report. And then the final report is supposed to be finished by the end of September, namely, especially on the 26th of September, it is supposed to be approved. And now I thank you for coming and for communicating or discussing so actively with us.
It's time for the buffet, and those of our fan club, our next performance is on the 25th of September. You are all welcome. It will be then on the European reference networks. So you're all most welcome and enjoy the buffet. For those who have to travel, have a safe travel home. Thank you.